Anita ma'am, we are live. You may start. Thank you. Anita ma'am?
Anita, start.
Yes.
A very good evening to everyone. Welcome back to day 2 of our weekend webinar series. I think we've had a very exciting day yesterday with a series of very stimulating talks and case presentations. It was indeed very well appreciated, as the statistics show. We had almost, I think, 1,650 views on YouTube and about 160 of them watching live. However, we have a very strong set of players for day 2, and we look forward to them breaking yesterday's record. I invite our president, Professor Sundaram, for the opening remarks.
Thank you. Hello. Good evening, everybody. Welcome to the second day of the weekend webinar in neuropathology. We had a great feast yesterday, and I look forward to today's program. I welcome Dr. Vaishali Suri from All India Institute, Delhi, and Dr. Chameli from Brazil, who are the speakers today, and also the moderators, Dr. MC Sharma and Dr. Nusrat Hussain, and the presenters who are from all over India. Welcome all of you, and I request Anita to introduce the first speaker. Thank you, Anita.
It's a pleasure to introduce my colleague and friend, Dr. Vaishali Suri. She is Professor of Neuropathology at AIIMS, New Delhi. Her passion is in the field of neuro-oncology, and she has several publications and honors in the field. Just before we start, however, a reminder, photography, recording very strictly prohibited. So just sit back, relax, enjoy, but please send in all of your questions through the chat box to make it interactive. I know we're all dying to hear Dr. Vaishali's talk. So I invite her to present her talk titled Adult Diffuse Gliomas, Setting the Stage for 2020. Dr. Vaishali Suri.
Good evening, everyone. And first of all, I would like to thank Dr. Anita Mahadevan and Sundaram Madam for giving me opportunity to participate in this webinar series. I'll be speaking on current WHO 2016 classification of diffuse gliomas in adults and what is in store for 2020. We all know that the classification and grading of the brain tumors for last century was based on histopathological characteristics, which was the mainstay of diagnosis and used to be supplemented with immunohistochemistry, and histopathological diagnosis provided the cornerstone for therapeutic decision making. But last 1 decade has seen explosion of molecular data, which has given us several tumor entities which actually do not match the conventional tumor classification model and grading system. And data from large-scale NGS datasets and transcriptome profile has given us better insights into pathogenesis of CNS tumors. We now know that brain tumor entities can be well characterized by a few set of cardinal mutations, which can not only be of diagnostic use, but can be prognostic as well as predictive markers. Thus, WHO 2016 for the first time integrated phenotypic and genotypic parameters, which has added not only objectivity for diagnosis, but given us prognostic markers and helped us in identifying unique therapeutic targets. And there have been significant contributions from India in the 2016 classification. If you look at astrocytic tumors, histology of the astrocytic tumors, it was still retained in 2016 classification. And diffuse astrocytomas, which are WHO grade 2, show moderately increased cellularity, and the tumor cells are seen in a fibrillary background. However, grade 3 tumors, the cellularity is high, they show hyperchromasia and presence of mitotic activity. Presence of endothelial proliferation and or necrosis is a hallmark of grade 4 glioblastomas. Oligodendrogliomas are very monomorphic looking, and you see sheets of monomorphic cells with typical fried egg appearance, chicken wire vasculature in the background, and dystrophic calcification. In grade 3 tumors, there would be increased cellularity, pleomorphism, brisk mitotic activity, the cutoff is more than 6 per 10 HiPA field, and presence of endothelial proliferation or necrosis makes them anaplastic oligodendroglioma WHO grade 3. Now, the markers which have been recommended for pathological evaluation of diffuse gliomas in 2016 are IDH, ATRX, and P53 mutation and 1p19q co-deletion. The glial tumors arise from a common glioma precursor cell. IDH mutation is an early event in gliomagenesis, and if this is accompanied by P53 mutation and ATRX mutation, it leads to the formation of a grade 2 astrocytoma, which can further then transform into grade 3 astrocytoma or a secondary GBM. If IDH mutation is accompanied by 1p19q co-deletion, then it leads to formation of an oligodendroglioma. The primary glioblastoma mutation. Am I audible to everyone?
Yes, Dr. Vesha.
Okay. Because it seems as if I am talking to myself. So IDH mutation is seen in majority of astrocytic tumors and is now considered hallmark of oligodendroglial tumors. And it helps in diagnosing these tumors even in small biopsies, distinguishing them. And some can be differentials of these tumors, like in oligodendrogliomas, there can be several differentials like clear cell ependymoma, clear cell meningioma, pilocytic astrocytoma, etc. I would like to highlight here that the IDH negative grade 2 as well as grade 3 tumors sometimes have a very dismal prognosis, which is equivalent to a glioblastoma. And IDH mutation can be diagnosed by a simple immunohistochemistry for IDH1R32H protein, which is the most common mutation it's seen in these cases. And if case is negative for IDH immunohistochemistry, then they have to be sequencing has to be performed for IDH1 mutation and IDH2 mutation. ATRX mutation is a key genetic alteration seen in majority of astrocytic tumors and is diagnostic of astrocytomas, and it can be diagnosed by absence of ATRX immunohistochemistry in these tumors, and it is mutually exclusive to 1p19q co-deletion. Although the concordance between P53 IHC and mutation is not much, but if you see 3+ positivity in any case, it has a very good concordance with P53 mutation. 1p19q co-deletion or loss can be assessed by FISH, and at our center we have kept a cutoff of 40%, and this is a molecular signature of oligodendroglial tumors, and it is not only a diagnostic marker but indicates a favorable prognosis and predictive for response to PCV therapy. Thus, if I summarize what was there in 2016, presence of IDH mutation, ATRX mutation, and P53 mutation is a typical molecular fingerprint of diffuse astrocytomas, and whereas IDH mutation and 1p19q co-deletion is a hallmark of oligodendrogliomas. Oligoastrocytoma term would be gradually removed from the classification, as with these markers we can very well classify a tumor as either astro or oligo. And WHO 2016 thus classifies astrocytomas as mutant or wild type. NOS category is used when you cannot use these molecular markers, and if a tumor does not fit into any of these categories or any known entities, then you use the term NEC, that is not elsewhere classified. By definition, oligodendrogliomas are IDH mutant and 1p19q co-deleted, which means these two alterations should be present for the diagnosis of an oligodendroglioma. WHO recommends a multi-layered reporting format, that is, there should be histological classification in the layer 1, followed by WHO grade, molecular information, and then integrated diagnosis in the end. For example, in oligodendroglioma, the integrated diagnosis would be oligodendroglioma, WHO grade 2, IDH mutant, 1p, 19q, co-deleted. So that means the layer 4 comprises of the histological as well as the molecular information. In 2016 classification, similarly, the glioblastomas were divided as wild, mutant, and NOS categories. And 90% of glioblastomas are actually primary GBMs, and these are IDH wild type. The markers which have been recommended for evaluation of glioblastomas are IDH mutation, which is mandatory in patients below 55, MGMT promoter methylation, TERT promoter mutation, BRAF V600E mutation, and histone K27M mutation. WHO recommends evaluation of MGMT in glioblastomas. In elderly GBMs, MGMT should actually be standard of practice because patients who have unmethylated MGMT, they can be given hypofractionated radiotherapy alone. Epithelioid GBM was a provisional entity in 2016, and now it will be considered as a variant of IDH wild-type glioblastomas. It is seen dominantly in children and young adults. However, it lacks specific diagnostic and prognostic markers. The clinical course is usually aggressive. And on histopathology, you see distinct epithelioid-like cells with abundant cytoplasm and peripherally located nuclei. They resemble a melanoma or a carcinoma. Necrosis, endothelial proliferation can be seen, and they are actually immunopositive for several markers like EMA, S100, Vimentin, GFAP, etc. Must use melanoma markers and markers for ruling out metastasis. INI1 should be used to rule out a rhabdoid tumor. And 50% of the cases of epithelioid glioblastomas, they show BRAF V600E mutation, and they lack classical molecular markers of a glioblastoma like EGFR amplification and PTEN deletion. Dramatic response to BRAF inhibitors has been seen in some of the patients, although the reports are anecdotal. Pediatric glioblastomas, we know from yesterday's talk that they are distinct from adult tumors, and identification of somatic histone mutations in tumors has given us two entities. I'm not discussing in detail because my talk is on adults. So diffuse midline glioma, H3K27M mutant, was newly defined entity in 2016, characterized by K27M mutations located in thalamus, stem, and spinal cord. And the prognosis is very, very dismal. They can resemble a grade 2, grade 3 astrocytoma or an oligodendroglioma, but immunohistochemistry for H3K27M protein is almost, immunopositivity is almost diagnostic of this entity. And new targeted therapies are also being developed for these tumors. Another entity which will be now released as a separate entity in 2020 is diffuse gliomas, H3.3 G34 mutant, WHO grade 4. It is actually distinct from IDH mutant wild type tumors as well as from K27M mutant tumors seen in cerebral hemisphere in children and young adults, and characterized by immunopositivity for H3G34R protein or V protein. Actually, glycine is replaced by valine or arginine. And ATRX loss is also a very good indirect marker to indicate presence of this tumor. Now, coming on to the pitfalls of WHO 2016 grading. This molecular classification, although was a major step forward, however, the grading schemes for the newly diagnosed diagnostic entities were not modified in parallel. The legacy grading system based on mitotic activity and anaplasia especially was subjective. Risk stratification for grade 2, grade 3 astrocytomas was not satisfactory. We could not substratify some group of tumors into this classification scheme, especially K27 tumors, mutant tumors, and G34 mutant tumors need their place in next WHO. And identification of molecular markers in diffuse astrocytic gliomas which can predict a clinical course corresponding to WHO grade 4 regardless of histological grade is the most welcome step. Am I audible to everyone?
Yes, Vaishali.
Please go ahead. Please go ahead.
So now what is in store for 2020? International group of leading neuropathologists who were directly involved in establishing the 2016 classification formed a consortium to inform molecular and practical approaches to CNS tumors. It is known as C-Impact Now group, and they have tried to communicate these changes in advance before the release of next WHO. Till now, 7 updates have been released by this group. And if I talk about the update 3 and update 5 released by these groups, these updates have given recommendations regarding the IDH mutant and wild type astrocytic tumors. For diffuse astrocytic gliomas, the group says IDH wild type and mutant tumors represent distinct clinical and genetic entities, despite similar terms used in 2016 classification, and they have suggested to reserve the term glioblastoma only for the IDH wild type tumors, taking into account that these tumors, even grade 2, grade 3, have a very dismal prognosis. Thus, the group felt since aggressive clinical course with overall equal or slightly longer survival than a classical GBM is observed even in grade 2, grade 3 tumors, there are several IDH wild-type tumors like ganglioglioma, pilocytic astrocytoma, Paksa, pediatric low-grade diffuse gliomas, which despite being IDH wild-type have a very favorable prognosis. So thus, lack of IDH mutation alone is insufficient for designating a tumor as grade 4. What we need implementation of molecular markers in diffuse gliomas, which can predict clinical course corresponding to WHO grade 4, regardless of histological grade. Thus, the group recommended that any IDH wild type diffuse astrocytoma, which shows histologically either microvascular proliferation or necrosis, or presence of any one of the molecular features of glioblastomas like TERT promoter mutation, EGFR gene amplification, or combination of gain of entire chromosome 7 and loss of entire chromosome 10, that is +7 -10 signature, which has now been modified to any change in, there can be 7p loss or 7q loss or 10p gain, 7p gain. So entire arm loss and gain is no more a criteria. In the next update, I will show you. These tumors should be called as diffuse astrocytic glioma, IDH wild type, with molecular features of glioblastoma, WHO grade 4. TERT gene is actually located on chromosome 5, and basically it encodes for telomerase enzyme, and abnormal reactivation of telomerase complex leads to cancer genesis and progression. And the hotspots mutations in the TERT gene promoter region has been shown to be a novel mechanism to activate telomerase in gliomas. Somatic mutations of TERT gene promoter have been documented in 80% of primary glioblastomas. In most common regions, 2 regions have been most commonly identified, C228 and 250. They have an inverse correlation with ATRX mutation, and presence of TERT mutation has been shown to be associated with shorter overall survival, which is more so in TERT mutant and MGMT unmethylated tumors. There has been a study in which TERT mutation was performed on almost all categories of gliomas, and this study showed that oligodendrogliomas, 90% of the cases they harbor TERT mutation, but even then they have a very good prognosis, and prognosis in this study was like the overall survival was more than 17 years in these cases. However, TERT mutant IDH wild type grade 2 and grade 3 tumors have the worst survival. Glioblastomas, either mutant or wild type, they show TERT a worse survival. And similar observations were made in another study, thus implicating that the utility of testing TERT is more in grade 2 and grade 3 astrocytomas, not in GBMs, because mutant as well as wild type GBMs, they show a similar prognosis. Now, if you test for TERT mutation alone, the specificity is around 89%, because you need to assess them for IDH also, because if it is TERT mutant as well as IDH mutant oligo, then it has a very good prognosis. But EGFR amplification and 710 signature have a very good specificity ranging from 98% to almost 100%. And again, I am going highlighting that 710 signature, any copy number changes is welcome. In a recent study in October 2020 on 87 IDH wild-type low-grade gliomas, the authors subclassified nearly 80% of low-grade gliomas were reclassified as grade 4 with survival which was equivalent to glioblastomas. We have done a similar study at our center and we could reclassify 20% of our grade 2, grade 3 gliomas as molecular glioblastomas, and the survival of these molecular glioblastomas was equivalent to IDH wild-type primary glioblastomas. But if you look at the lower panel here, I would like to highlight that the panel negative grade 2 tumors had a very good prognosis, and panel negative IDH wild-type grade 3 astrocytomas behaved like GBMs. So I want to highlight here that our data says that IDH wild-type grade 3 diffuse gliomas behave like GBM irrespective of their molecular profile. In the update 6, it was felt that let us simplify this term. All these tumors which are molecular grade 4 should be called as IDH wild-type WHO grade 4 tumors, just for simplification. Now I come on to the reclassification for the mutant tumors. In their update 5, the group discussed that grading and nomenclature for the IDH mutant diffuse astrocytomas also needs a change. So they have suggested for conversion to a single name astrocytoma IDH mutant. So they want to discontinue the term glioblastoma. The Roman numerals for grade 2, 3, 4 should be replaced by Arabic numerals. Histological features like mitotic activity, microvascular proliferation, and necrosis should be retained. And they have introduced a new genetic marker, that is CDKN2A. If homozygous deletion of CDKN2A is present, then irrespective of any histology, the tumor would be called as grade 4. So I'm talking about grade 2, 3, and 4 tumors. This was based on the analysis of several studies in which presence of CDKN2A homozygous deletion was most consistently associated with worse prognosis despite lower grade of the tumor. Now I have gone through several studies. So this is a study from year 2015 in which 270 gliomas from UCSF were analyzed. The fish cutoff was 20%. Homo as well as hemizygous deletion was considered. And as you can see, a substantial proportion of grade 2, grade 3 astrocytomas and oligodendrogliomas showed CDKN2A deletion. But CDKN2A loss was associated with poor survival only in astrocytic tumors. Now look at this another study in 2018 by Shirata et al. In which they have tried to analyze methylation data and they have taken copy number profiles from their methylation data. Interestingly, none of the grade 2 tumors have shown CDKN2A deletion. Only 15% grade 3 tumors have shown this alteration, and they have said that this alteration is most powerful parameter only in 3 and grade 4 tumors for their prognostication, and they did not find any of their grade 2 case did not show CDKN2A deletion. We have done a study on glioblastomas in which we have seen that at all ages you can see CDKN2A deletion in glioblastomas, especially in age more than 40 years. Most of the glioblastomas harbor this alteration, and we have also shown that P16 immunonegativity is a very good surrogate marker. And another study, we have shown that there are other mechanisms of loss of P16 expression which are responsible for worse prognosis in glioblastomas, especially strong EZH2 expression, which needs to be looked into in future also. Thus, the proposed terminology for next WHO for IDH mutant tumors would be any tumor which is diffusely infiltrating, IDH mutant showing microvascular proliferation or necrosis or homozygous CDKN2A deletion, or a combination of these would be called as astrocytoma IDH mutant grade 4. But look at this study in 2020 by Marker et al. 108 primary and 43 recurrent IDH mutant tumors using a cutoff of 30%. He said that it is very rare. This homozygous deletion is very rare in primary tumors and is more frequent in recurrent tumors. And they could stratify only histological grade 4 tumors. Grade 2, grade 3 tumors did not show. If you look at the first graph, more than 30% threshold was not identified in any grade 2, grade 3. So we need definitive criteria for determining CDKN2A homozygous deletion. So I went through other studies also, and if you look at the data, the frequency of CDKN2A homozygous deletion varies from 0 to 3.5% in grade 2. Only study which shows 45 is he has taken a cutoff of 20%, and both homo as well as hemizygous deletions have been considered. So we need to be very, very careful before we implement this marker. So I would like to highlight here to the group that there should be some important considerations before considering this marker. Number one, the wording of C-impact now proposal is not clear. Whether we are going to use this marker for grade 2 tumors, it is not clear to me. If we are testing this marker in grade 4 tumors for deletion, it might give us a very low yield, might lead to inappropriate upgrading of these indolent tumors, and might impose an undue financial burden. So we need specific criteria for determining presence of homozygous deletion. We need what cutoff should be used. It should be uniform, at least in our country. And we need to have a uniform policy which technique we'll be using. For us, I feel FISH is the best technique which can be used in most of the centers. Now, the scheme which we propose for evaluation of wild type and mutant tumors is that first you look at the histology, then use ATRX IHC, IDH. If negative, then do Sanger sequencing, especially in cases less than 55. Do P53 IHC. 1P19Q can be done only on the cases, we do only on the cases where ATRX loss is there. Otherwise, we do not do if 1P19Q is there with IDH mutation. Then if these two are present, it almost indicates presence of an oligodendroglioma. Now, in a mutant case, IDH mutant case with ATRX loss, CDKN2A homozygous deletion should be assessed for. If present, will be called as astrocytoma IDH mutant grade 4. In a wild type case, you will use the panel of 3 markers, that is EGFR amplification, 7 plus 10 minus signature TERT mutation. And if any of these is present, even presence of a single marker or a combination, then we will call that tumor as a glioblastoma IDH wild type WHO grade 4. Thus, to summarize, the immunohistochemical markers which you can use in your laboratories are IDH, ATRX, P53, H3K27M. H3K27ME3, absence of nuclear staining is a very good surrogate marker for presence of mutation, and in difficult cases you can use these two markers together. Then G34R and V, BRAF V600E IHC can be used, but it gives good results only with Ventana. And MIB labeling, of course, should be performed in all cases. Assessment for 1P19Q, CDKN2A, EGFR, and P10 should be done by FISH, but we have to be very, very clear about what cutoffs should be used. We should not be using cutoffs like at one center, some cutoff is being followed, at other center, others, then we are misleading the literature, we are misleading everyone and even the patients. TERT mutation, IDH mutation, H3F3 mutations can be analyzed by Sanger sequencing. Thus, to conclude, it is very critical for pathologists to recognize diversity of molecular testing which is nowadays available. We should know which tests to order, how to incorporate this molecular data to provide best patient care. Introduction of these new technologies has led us to a stage where we need extensive adaptation to the current clinical practice. In places which do not have access to such technologies can generously use the term NOS. And we need to, last but not the least, we need to improve the molecular detection methods, which should be very clear and very specific. The descriptions of algorithm which are going to be used to judge these molecular alterations need to be very clear and specific. And I would like NPSI members to highlight these, and we should work as a team on making all the changes and recommendations. And what we need is optimal evidence-based translation of novel insights into clinical diagnostics. Thank you very much. Any questions?
Thank you, Vaishali. It was an excellent lecture on the current status of the diffuse adult gliomas. You have given the guidelines as to how to go about these various things in the routine practice. I think now we will take the questions. Dr. Anita?
Thank you, Vaishali. I think you've set the pace today with your very customary, powerful, clear, lucid, comprehensive talk.
Thank you for your kind words.
There are a couple of questions and a lot of congratulatory messages on YouTube. Dr. Nuzhat has asked a very pertinent question. What is your take on methylation classifiers? Is the DKFZ classifier going to be a part of the WHO system?
See, methylation classifiers, of course, would be a part of WHO classification system, but if the question is, can we implement in our country, that is the major question. Because for methylation analysis also, you cannot do methylation of one particular tumor. I mean, you cannot give one sample. It has to be a batched assessment. Then you need 40,000 cases per case, 40,000 rupees per case here. And then you need a very good bioinformatics team also. So I really don't know how we are going to implement this WHO 2020. We have already started implementing the markers suggested for the mutant as well as wild type cases. But believe me, it takes a lot of time and energy, even doing fish.
Dr. Nuzhat, would you like to give your opinion?
Well, yes, actually, I'm kind of scared because that's why I asked a question, and Vaishali had done like a huge, a detailed study on the high-grade adult diffuse gliomas. So I believe that there is a huge push for it, and this particular classifier, which is the DKFZ one, is being pushed by the people who have come up with it to actually classify the high-grade ones. And so in that case, it would actually mean an absolutely new technology for most labs, because what we are looking at right now is just like single gene efforts, either through a molecular IHC or through a fish methodology. And at the most, people have to do NGS. And from what I understand, NGS is also not exactly a very comprehensive thing to do, because a lot of your genes get left out there. Like the TERT is usually not covered in the NGS, and so are not your genes. So I guess it's a scary way ahead. I hope that the 2021 will be more conducive to application all over the world.
Probably we can take a couple of more questions which have come in from the YouTube chat. Do you recommend PTIN by IHCs one?
No.
Vaishali?
No.
It's a no. I'm just trying to go through what else. Can P16 be used instead of CDK and 2A is one more question.
Earlier, we had, as I've shown, we had done a study. P16 immunonegativity was, it very good concordance with the deletion, but its presence, I don't know. And secondly, now we are trying to use this Ventana antibody, and in a month or so, we'll come up with this thing, a good number of cases where we can actually say P16 will work or not. So we have just started using it. But it is very tricky, Dr. Anita. Like the situation is that, like grade 2 tumors, should we not do CDK and 2A? That's the question I am asking the board, Dr. Chitra Sarkar, Dr. Vani Santosh. They have to come up with some recommendations.
I think that's a very good suggestion that NPSI should probably sit down and make our own recommendations.
Data, I was astonished that there is so much variability because the cutoffs are different. Somebody is taking homozygous deletion, someone is taking hemizygous deletion, and with stringent criteria, grade 2 tumors do not show. So can we keep it restricted only to tumors where we are, suspecting like a borderline case, where we are thinking it is grade 2 or grade 3, where we, that would be just a recommendation.
I think there's a lot of discussions that we ourselves have to have amongst ourselves to come up with a solution to that. Dr. Kirti has a very practical question for you. She says, while often the IDH1 IHC doesn't give robust results, it is a starting point of any stratification. So do you have any suggestions on the conditions, the clone, etc.? What they are using is diary.
No, we are using the Dianova clone, and as I have talked about it earlier also, sometimes it starts giving very, results like the dilution after keeping this antibody. After some time, you need to do it in 1 in 40, 30 dilutions. And earlier it starts working in 1 in 400 or 500, but later on, it starts working only in 1 in 20, 30, 40. But with the Dana system, it is giving somewhat good results.
Yeah. She also wants to know, do you do sequencing in those that are negative?
Yes, we are now, since 2020 classification is coming up, and it is now being mandatory in all cases. So we are planning, we will do IDH in all IDH negative cases, we will do sequencing. Yes.
Yeah. I think Dr. MC Sharma has his usual practical tips. He says use a higher concentration and put controls on every slide, is Dr. Nazat's advice. So there are several other questions. I think, Vaishali, you've stimulated a lot of interest, and obviously this is a topic that everyone needs to know everything about.
Yes.
But in the interest of time, I think we will... Sorry, Vaishali, we lost you there.
I said I learned a lot preparing for this talk.
That's okay. So in the interest of time, I think we will go on to the next speaker. Thank you, Vaishali. Thank you very much. I'm sure everybody enjoyed it as much as I did. It's a pleasure, I think, to invite our second speaker, Professor Laila Shimeli. It's a real pleasure to have her with us. I know she needs no introduction to this very august gathering. She's a giant in the field of CNS infections, particularly parasitic diseases. Just for the record, she did her neuropathology training and PhD from Queen Square, London, the Mecca for neurosciences. She served almost for 2 decades at the Federal University of Rio de Janeiro. She's currently coordinator of the Neuropathology Lab at the State Institute of Brain since 2013. She has several publications. She has textbook chapters. All of the chapters in Greenfield, most of it on CNS infections, has been authored by her. And I must say, Dr. Shimeli, we use it as a Bible for our routine reporting. She has also served as an archivist, and she was the vice president of the International Society of Neuropathology. It's a real pleasure to have you with us, and we invite you to present your talk on your experiences on parasitic disorders of the CNS. Dr. Laila Shimeli, please.
Good morning. Thank you very much. Thank you very much, Dr. Anita Mahadevan, for the invitation. Thank you, Dr. Sandra. It's a pleasure to join you and present my experience with parasitic infections. Can you see?
Yes, ma'am.
Yes, we can.
So I can start now. So I'm going to show you the experience we have in Brazil, particularly the protozoal infections, Toxoplasmosis, Amebiasis, Malaria, and Trypanosomiasis, and Metazoal infections, Ceristicercosis, Schistosomiasis, Hidatidosis, and Strongyloidosis. The last one, very little experience. As you know, Brazil is a very large country. I'm here in Rio de Janeiro, and here is the Amazon region. and here is in Minas Gerais, São Paulo, and so some of the infections are more frequent in some regions, and I'm going to tell you during the presentation. So starting with the protozoal infections, toxoplasmosis, which is the first one. No, sorry, it's in the other. Sorry, amebiasis I'm going to show first, sorry. So amebiasis can be caused by either Entamoeba histolytica, which is known for many years as a parasite which causes abscess, but more in the last decades, free-living amebas were described, mainly Naegleria fowleri and Acanthamoeba, Balammutia mandrillaris, which give different types of infections. The first one, Naegleria fowleri, primary amebic meningoencephalitis, mainly related to people who swim or in contaminated water. And these ones which are mainly occur in those which are undernourished or have immunodeficiency. So my experience is mainly with this one, not with Naegleria fowleri. And cerebral involvement may be fatal. So this is a case that we had in the 90s, just at the time, in the late 80s, beginning of the 90s, in the last century, when AIDS was very frequent. And the lady, a 40-year-old lady, presented with this lesion, a necrotizing lesion. We thought that she had AIDS, but in fact she didn't have. She was undernourished. She had other causes for immunodeficiency. And this is another area of the same brain with the foci of hemorrhagic softening. We thought we were going to find the toxoplasmosis in this case, but in fact, we found in the cerebellum also had some lesions like these, necrotizing lesions. So we had necrotizing lesions here. This is a part of the cerebellar folia, which is inflamed. There is a lot of inflammatory infiltrate, mainly lymphocytes, necrosis of the cerebellum. And in some areas, there was granulomatous reaction with giant cells, like here, for instance, giant cells. And then in other areas, we could see several parasites surrounding vessels, like here, and then some inflammation close to related to necrotizing lesions. And we identified this as amoeba. And we sent it at the time for Dr. Martinez and Visvevara in the United States at CDC. And they identified as Balammutia mandrillaris, which is one of the causes of granulomatous and amebic encephalitis. This is another case. This is from a colleague from the northeast of Brazil, who also showed the case in a meeting we had here, some of these amebas, which we need to think of them, because otherwise we may think that these are macrophages, they are, with H&E, they are poorly stained. So these are some of the amebas in this granulomatous amebic encephalitis. They stain with Giemsa. So here is that first case, the autopsy case I showed you with several amebas stained with Giemsa. They also stain with PAS, as we can see here. And these are cystic forms. So in some cases we see a capsule. And this is a case of, this is an Entamoeba histolytica taken from, is an old case of amebic abscess, which we don't see frequently anymore, but this is an old case from the archive with Entamoeba histolytica in the wall of a brain abscess. Cerebral malaria is also a parasitic infection that we see in Brazil, but not in the region where we live. It's mainly in the north of Brazil, in the region of the Amazon, but also in the west. And it's caused by Plasmodium falciparum. It's acquired by the bite of an infected Anopheles mosquito. It's a major health problem in many regions of tropics and subtropics. Infants and children are particularly affected. And cerebral malaria occurs in the severe form of infection. It's a rapidly progressive encephalopathy with various degrees of consciousness loss and fits. Usually there is a reversibility of symptoms, and neuropathology helped understanding the pathogenesis. So this is found mainly in the north of the country and also in the west of the country. Sequestration of parasited red blood cells by the microvasculature in vital organs. And then this is also this is all the pathogens. I'm not going to explain it all here, but there are several in the macroscopic appearance, and microscopically there are hemorrhagic petechic rings with petechics and ductus granuloma. So this is a case. The only case I saw, in fact, is that I was working in the state of São Paulo many years ago, and this is a person who traveled to that region and he got malaria and he died in the hospital where I was working. So it's this is a typical presentation with several petechia involving the white matter. And here there are some of the pigment, the hemozoin pigment in the blood vessels. There are the petechia, and there is usually severe gliosis and microgliosis. Again, another area showing the petechias. And then toxoplasmosis. Toxoplasmosis, yes, we have a large experience, particularly with AIDS. And we all know that it is found in immunodeficiency patients. And the acquired form can be seen in the pseudotumoral form, but also in rare occasions as an encephalitic form, which we saw recently in case, for example. And there is the congenital infection as well. So this is a typical image we saw AIDS started, but we are still seeing nowadays with this lesion, pseudotumoral lesion in the basal ganglia, deep. See, these are some pictures of the autopsies at the time of the 80s, 85 from 92, 93, when we're still seeing lots of autopsies of AIDS patients who died with toxoplasmosis. So this is a necrotic lesion, deep necrotic lesion, but usually there were others also, several lesions. So these are some of them. Here again, this is another one. Some of them are hemorrhagic in several stages also. Some are already absorbing again. So these are several presentations. So nowadays we are not seeing autopsies anymore, but we are receiving biopsies of patients with toxoplasmosis. So histologically, there are microglial nodules. There is extensive necrosis, which is known as a dirty necrosis. There are several debris of nerves of degenerated cells. And here we see again inflammation around the vessel. And here we can see the parasite, as you all know, a cyst. And here we have again these are free forms, these are cysts, this is the immunohistochemistry, and this is the typical presentation with electron microscopy. And this is just a picture of toxoplasma stained with immunohistochemistry. But more recently, not so recently, but after treatment was started and patients survived, we started seeing some cases with in which the infection was not active anymore. So there were areas of cavitation like here and here again. So these are either treated cases or burnout lesions in which inflammation was hardly seen. Also, the parasite could not be seen. In these cases, what we could see was cavitated lesions full of macrophages here in the cerebellum, here close to the ventricle is one of those I showed of treated cystic lesions. And the parasites in this case could be hardly seen, sometimes with immunohistochemistry. This is not a very good picture, it's out of focus, but this is a smear we saw recently in a biopsy from a patient who was not known to have AIDS. And we found these free forms of toxoplasma. And also here in the smear, we can see this structure here. And in another area, we could do immunohistochemistry, and it was positive. So toxoplasmosis, as you know, can also be congenital. So in these cases, because the brain, the fetus is also immunodeficient. And so in this case, there is a destructive lesion, necrotic lesion. I have another one, which is better here. So there is a calcification, necrosis, the brain is completely destroyed. Cut sections, we see these yellowish areas, which are all necrosis, and also the cerebellum, and also the spinal cord. And this we could compare with what we saw in the last 5 years with Zika, because this is also a cause of microcephaly. In this case, we examined at the same period in 2016, when we were examining cases of Zika. And although there is also calcification in Zika, we do not see the necrosis, active necrosis, as we see in toxoplasmosis, as we are seeing here. So the destruction has been done, and we see calcification, but the extensive destruction of the brain, but not active necrosis. Well, trypanosomiasis, as you know, there is African and American trypanosomiasis. I'm going to talk quickly about the American trypanosomiasis, which was described by Carlos Chagas. So it's called also Chagas disease. Trypanosoma cruzi is endemic in South America, especially in Brazil. So there is also in Argentina, and in Brazil is mainly in the states of Minas Gerais and São Paulo. I'm going to show you in a moment. Usually, the lesion is particularly in the autonomic nervous system. So the patient has megaviscera, and the CNS involvement is uncommon. When I worked in the state of São Paulo, we saw several patients, several autopsies of patients with chronic Chagas disease, and we didn't find any specific lesion in the brain, only infarcts because of the vascular disease, because of the cardiomegaly, the cardiac involvement. But then, since this was in the 90s, from 1922 to 1927, and when AIDS was still very frequent, and in that region, Chagas disease is endemic. So I found a case of extensive necrotic lesion. I'm going to show you in a moment. And this was, in fact, a reactivated Chagas disease. The patient was hemophilic. Since he was hemophilic, he was taking blood, he was taking platelets. And because of this, he got Chagas disease, because that region is endemic. And the lesion, we were amazed when we saw this brain with an extensive necrotic lesions, different than toxoplasmosis, because it's not a pseudotumoral, it's more an encephalitic diffuse necrotizing lesion. And when we saw the histology, the amount of parasites was enormous. In fact, they look like toxoplasma because it's also protozoa like toxoplasma, but they are larger and they infect many more cells than toxoplasma. Here we see a detail of these parasites in cells. And there we had the antibody for Trypanosoma cruzi, and it was positive. And here we can see again some large cells. It seems that there are nerve cells that are infected here. And then I saw another one there. So I saw two cases of reactivated Chagas disease with extensive necrotizing lesion. The brain here was not very well preserved. And so this is Chagas disease. So going now to metazoal infections, we have Cchistocercosis that you also have experience, but I'm going to show you quickly that Cchistocercosis is the larval form of Taenia solium. And frequent parasitosis in the CNS. There are several countries, as you know, and humans are the intermediate hosts after ingesting the ova of the solium. And they develop into larvae, penetrate intestinal wall, invade lymphatic and veins, disseminate to skeletal muscle and CNS. and clinical features depend on the number and locations of the cyst. So this we saw occur in Brazil in several regions, but mainly in Minas Gerais and São Paulo. And in that region where I work here in the interior of São Paulo, I saw several cases of cysticercosis. And so these are some of the cases. We can have several cysts. This is a typical picture of an extensive diffuse lesion, the image. And here we have the scolex. And here we have another one, is another brain I examined there. We can see a viable scolex here on the right, and the degenerate scolex here in the thalamus. It is yellowish. And here is the picture of a low power of a scolex, which is here, and here is the cyst wall. This is a detail of the scolex. And but it's not common to find the scolex. Sometimes even mainly in surgical specimens, we can see the wall of the cysticercosis, and we have to make the diagnosis with this. So this is the typical wall. This is available. So there is still inflammation, the debris, cellular debris, some small cysts, but many times what we found are degenerate cysts. So we need to know this appearance of this wavy appearance of the surface of the cyst, because sometimes we only find this degenerate structure and we have to recognize it to make the diagnosis of cysticercosis. The adjacent brain has inflammation, sometimes giant cells. And here is a case, for instance, this is completely degenerated. We can hardly see any structure, but we can see this appearance with some, when we know that we recognized as a degenerate cyst or sometimes degenerate scolex. So when it calcifies, we can see here, this is a tomography, and here's a calcification, a calcified structure in the cortex. And this is how it appears after it's calcified, hyalinized and calcified. And these are the racemose form. We do not see the scolex, but we see these large structures, large cysts like grapes here. And these are from the Minas Gerais, from a colleague called Dr. Pitella, who gave me these pictures. This is a case I saw, racemose cyst. It usually occurs in places where there is space left in the cranial cavity, like the ventricles, like this area here. So we can find them. And then the inflammation in the tissues is sometimes very strong when the cyst degenerates, and this gives these ring enhancement lesions in the images. This is just a hyalinized and calcified cyst. Doesn't go for, sorry. It doesn't go forward, sorry. I don't know why. It's stuck here. That's what I can do, so.
The pictures are so beautiful, Dr. Chimeli. We are not, it's okay. We're enjoying it.
Sorry, I don't know what happened. It doesn't go forward nor. I really don't know what happened here.
Dr. Aditya, can you help?
Now we go. Now it's okay. This is etidosis. Etidosis also is not a parasite that I have experienced. Is caused by Echinococcus granulosum. This is more frequent in the south of Brazil, close to Uruguay and Argentina. So is also a case I got from a colleague. And in fact, there is a thick wall outside, external, and then there are this is the internal part where several small scoliosis with hooklets are seen. But this is mainly related to sheep, to the places where there is sheep. Now, schistosomiasis, yes, this is also common in Minas Gerais, in the west of the country. And it's called by Schistosoma mansoni in Brazil. There are others, as you see, and this one is in Latin America. And the shape of the eggs is what differentiates one from the other. And so the adult schistosomes inhabit blood vessels through mesenteric and pelvic plexus around the bladder. Ova are deposited in blood vessels and lodged in venules. Some rupture venules all into the bowel or bladder and are excreted in feces or urine. Once in water, embryos, which are called miracidae, hatch from eggs. They penetrate snail where larvae, which called cercaria, develop. They emerge into water, entering the skin of the definite host, and they invade blood vessels to mature into adult and male and female. And what we see, the neuroschistosomiasis is uncommon, so CNS involvement uncommon, overreach the CNS by retrograde passage through the portal mesenteric and pelvic veins and valveless vertebral venous plexus of Batson. Anomalous migration of this adult close to the CNS and in situ egg deposition is the way it reaches. And thoracic and lower spinal cord are common locations. I saw one case, an autopsy case, also in the region of São Paulo, and I also have some given from my colleague, Dr. Pitella from Minas Gerais. This is an image of a lesion in the brain and cerebellum. So what we can see are granulomas, granulomatous lesions, and sometimes we see the eggs, which are here. Sometimes they are involved by giant cells, and this is the case I saw. This is the spinal cord. This is thoracic spinal cord, which is usually thin, and it was swollen. It was, in fact, the whole spinal cord was the same thickness, and here we see the sections from the cervical to the sacral. So this is the thoracic, which should be thinner, and it is this area here. When we had the histology, we saw several. In fact, unfortunately, the picture is not very good, but several granulomatous regions with giant cells, and many of them had the eggs. So this is schistosomiasis. And the last one, which is, I saw only one case, and this was when AIDS was very common, was strongyloidosis. So as you know, this is an intestinal infection, and but occasionally the larvae pass through lungs and mature in duodenum and jejunum, and during systemic migration, they may end up in ectopic sites like the CNS. They are not common, but the only case I saw was diagnosed, in fact, first in the CSF. This is the picture of the larva in the CSF, but then the patient died. We examined extensively the brain, and we found just in the meninges this larva here without any inflammation. So it's just a single larva I could find, but with this information in the CSF, we diagnosed as meningeal strongyloidosis. So these are the experience I have, and I thank you very much. And I'm showing a sunset in the beach in Rio de Janeiro. Thank you very much.
Anita, ma'am?
Thank you, Dr. Shimeli, for that phenomenal talk. We really enjoyed it was a treat, I think. The illustrations were so beautiful. I guess India and Brazil share almost identical spectrum of CNS infections, which is what made it so interesting, except probably for trypanosomiasis, which we haven't seen. It has, there have been some questions which have been thrown by the audience. I think the first one is by Dr. Sharma, who asks, does vasculitis occur in amoebic infections?
In what? Sorry.
In CNS amoebic infections, Amebiasis?
The cases I saw, the few cases I saw, just 2 cases. They had the tendency to locate around the vessel, I saw, and also there was inflammation around it, but I didn't see the real vasculitis in the wall, the real vascular inflammation along the wall. There was some perivascular inflammation located related to the presence of the amoeba, but this is my experience with only 2 cases. Maybe there are. I didn't check, in fact.
Very rich experience, Dr. Shameli. It is like an atlas of the parasitic infections. We do share such kind of things, but as Anita already said, Trypanosomiasis and Schistosomiasis common. Do you have an experience with paraganosis?
Which?
Paraganosis.
No, I don't.
Have an occasional.
No, I don't.
Entamoeba we see very rarely. Entamoeba we see very rarely. Still we do get this, but you have such rich experience. Wonderful talk, Dr. Shameli.
Dr. Shameli, there is one more question which Dr. Nuzhat Hussain has said. She has done a lot of work on experimental cysticercal infections too. She asks whether racemose intraventricular form of cysticercosis, which is very rare in India, is it due to any kind of a genetic variation? Do you think that's the reason why it's rare in India, is what she asks?
I would have to read again. Sorry, I don't remember if that, because these cases I saw when I was working in São Paulo. Then I was really up to date with the literature. But here we hardly see any cases, in autopsy we don't see. But I think yes. But in fact, I'm sorry, I cannot answer with certainty. Sorry. I know that they form in places where there is more space, but and I don't remember the pathogenesis. Sorry.
Probably an interesting question, which currently we cannot answer. There is one more question which has come from one of our participants, Dr. Ishani. She asks whether there can be any other cause of granulomatous encephalitis other than tuberculosis, fungus, and amoeba. So
let me think. Granulomatous encephalitis, I think so, but the fungus, amoeba, and a fungus. No, I'm thinking of several fungi. In fact, we have paracoccidioidomycosis here. We had just had a case of cryptococoma. Not that I remember now.
What about parasitic itself?
Help me. Maybe you can also help me with your. I don't remember now. Sorry.
I was just wondering, we often see this cysticercosis forming chronic abscesses. Have you ever seen it? It would be all the layers of a chronic abscess, a central lumen, but walled in by palisading epithelioid cells with giant cells and a very thick fibrous encapsulation. But if you search, sometimes you'll see calcospherules of cysticercosis. We tend to call it cysticercal abscess, but I don't see that terminology in any publications or books. I was wondering whether you have any such experience.
No. I only saw giant cells. Sorry. I saw giant cells in around the cyst because of the inflammation, but not forming the granuloma itself.
Maybe another genetic variation.
Yeah.
So I think we're running out of time. There are several more questions, including toxoplasmosis also can produce granuloma, is one comment. So yeah, I think questions will never end. We really enjoyed the beautiful talk. Thank you, Dr. Shameli. We'll go on now to the next exciting session. I think everybody is waiting for it. We have the case discussions and two stalwarts who are going to be chairing this. We have Dr. Nuzhat Hussain who's Professor and Head, Department of Pathology, Dr. Ram Manohar Loya Institute of Medical Sciences, Lucknow. And her expertise in the field of oncopathology, molecular pathology is, I think, very well known. And co-chairing this will be Dr. M.C. Sharma, Professor of Neuropathology from AIIMS, Delhi. He's, I think, a Master of